we're going to discuss a number of test results focusing on the neurotransmitter today, right? And what we can do is I'll try to share the screen for this one patient with some of the results. Maybe I can start with the neurotransmitter results first, right?
Well, Dr. Chan, perhaps it's a good idea just to give us a little bit of a background of the patient.
Yes.
In regard to, because you've done a lot of testing, functional testing for this patient, and we need to
Yes.
really get an understanding as to what the background is and why we choose functional testing. Okay?
Right. Sure. Yeah. So this patient is a male, and he is around mid-50s, right? And he's having some issues with sleep mainly, right? So there are the sleep disturbances whereby the either onset or waking up several times in the middle of the night, and he finds it difficult to sleep, right? So that is one of the main issues. All right. Yeah. So
is he on any medication at the moment?
Well, since
was he taking any medication prior to you seeing him?
Yeah, not medication as such, but we have prescribed some supplements for him. Mainly
this is after the testing, but before testing, was he on any other medication?
It won't be before testing, because we allowed our patients the option of doing some basic relief, because the test results would take a couple of weeks to come, right? And definitely we will review the results when they arrive. So yeah, so we try to do some basic intervention. We offer our patients that choice. And so in this particular case, yes, we have prescribed melatonin, 3 mgs, and also a broad base of amino acids to increase, especially the 5-HTP, to which would increase his tryptophan, which I believe would be then converted to melatonin to help the patient sleep well. The serotonin, to melatonin.
So you've done a number of tests for this particular patient, and thank you so much for sharing all his results with us.
Yeah.
You've done neurotransmitters, his adrenals, his hormones, and it makes sense, because often sleep is a precursor, an imbalance of issues associated with sleep, whether it is onset, which is melatonin associated, or whether it is latency, which is GABA associated. Irrespective of what the dynamics of that sleep is, we often find that sleep has an underlying causative factor or driver, and one of the drivers is often stress. So you've measured his cortisol, he's over 50, so you've measured his hormones. You've also measured his food intolerances, and and what was his occupation?
He's a consultant.
He's a consultant. So it's quite interesting that being a consultant, he's not really exposed to heavy metals, but there were quite a few heavy metal exposures. So let's unravel some of his test results that you've actually done. And I must admit to the audience that this particular neurotransmitter result that you have is quite unusual. Most people are serotonin deficient, not serotonin excessive. So this is quite an unusual case. So let's go through it. Do we go through one test at a time?
Yes. Would you be able to share the screen from your site?
Yes, I
It's a
can.
yeah.
Let's share. Let's do
Yeah.
the share
So
screen.
so
Sure,
yeah.
sure.
So so you can do that on the PDF.
Not a problem. So we had his, was this the
Yep.
neurotransmitter?
So you want to do?
Okay,
Yep.
let's do
Okay.
that. Let's do that.
Right.
All right.
Yeah.
So what we have is a patient who's had a number of things measured. Okay, so let's just go through this in a little bit of detail. I'm sure that if there is a lot of education material available, and I'm going to share with you some links where you can actually access this information. You also have access to this information in the book that I've written called Alchemy of the Mind, as well as Alchemy of amino acids, and that's available through Dr. Chan.
Fantastic.
Now, when we look at a test result like this, most of our patients are actually serotonin deficient. In other words, they're depressed. In this case, we see a serotonin that's rather high. Now, it's very important to look into these results, not relative to its own reference range, but relative to an optimal reference range, which is down the bottom. So as we can see that the serotonin is 431, ideally you want it between 100 and 215. Now, why would that serotonin be so high? There might be genetic polymorphisms. Example, if a patient is perhaps a drug taker. High alcohol or high caffeine content, that affects, or basically MDMA, which is ecstasy and cocaine, that can affect the genetic polymorphisms, which can artificially raise serotonin. If a patient's on an SSRI, then that blocks that, it inhibits that SERT receptor, it blocks the serotonin reuptake transporter enzyme, and that can also cause an artificial high. So what we need to do is, we really need to think about that receptor binding. There's a failure in that receptor binding, and what causes that increase is also high cortisol. Now, we will look at his cortisol results, and we can see that he's really wired and tired because his cortisol in the morning is really high, and we'll explain that in a minute. So to drive down that excess serotonin, we need to give this patient inhibitory agents. Not only melatonin to help his sleep onset, but we can see that the GABA is only 339 and it should be between 400 and 600. So if he is GABA deficient and serotonin excessive, he's not able to sleep. He's not able to relax, and that's a GABA trait. So therefore we need to actually, he's got anxiety, he's probably palpitating, he's choked up, etc. So we really need to actually rectify those inhibitory pathways by supporting GABA. Now, how do we do that? We can give the patient L-theanine, we can give the patient SAMe, vitamin B2, herbs such as feverfew is also a really great herb to actually help drive down that excess serotonin and push up GABA. That's the first strategy. That is number one that we have to deal with. Now we have a look at the rest of it. We can see that histamine is what's histamine? 25 should be under 15. So that means that this patient has a methylation defect. So we'll discuss the methylation in a bit. So obviously, useful.
Right. And that was actually what prompted us to do the food allergy, because this enhanced histamine led us to think maybe he had some food allergy, but then we didn't find it, as you would see from the results. So it could be because of methylation.
We'll go through that one in a minute, and I'll explain. Just take note of the fact that when a patient is stressed, they likely do be acidic. So it's very important to maintain the alkalinity in that particular patient. The next thing we see is that the excitatory pathways, always, when you're doing a neurotransmitter, always rectify the inhibitory pathways first. Then start to rectify the, allow for a couple of weeks, 2 to 3 weeks of inhibitory support before you start looking at excitatory pathways. Now that dopamine is high.
Right.
A patient who is taking a lot of alcohol, patient who is addicted to drugs, patient who is caffeine addicted as well, are likely to have elevated levels of dopamine. So a patient's antipsychotics actually block dopamine, and to really drive down those hallucinations in, let's say, in schizophrenia. Any level of high levels of cortisol will actually elevate dopamine as well. So dopamine correlates quite well with, there's a good correlation between hormones and neurotransmitters. So we'll go through that when we see his neurotransmitter results. Now, this is quite interesting. Hyperthyroid patients, they tend to block an enzyme called dopamine beta hydroxylase. This is an enzyme that converts dopamine to noradrenaline and adrenaline, the catecholamines, right? So if the patient is likely to be hyperthyroid, that'll block the way dopamine converts to catecholamines, and that in itself will raise dopamine. So you therefore need to look at, is there a problem with thyroid dysfunction? So to drive down that dopamine, we need to give the patient some SAMe, we can give the patient vitamin C, copper. Copper also stimulates dopamine to noradrenaline pathway. What else can we see here? Now, adrenaline is very high. Now, when adrenaline is high, we know that this patient is on a flight-free system. So they are pushing their adrenals to the limit, right? What do we do? We need to give them meditation techniques. You, as a psychologist, you give them your CBT, DBT, ACT, etc. You also need to give them adaptogenic herbs like ashwagandha, withania, kudzu, shatavari, rhodiola. These are fantastic herbs to actually drive down that elevated adrenaline. So we need to support that so that they're not in this flight, freeze mechanism all the time. Now that we've got the neurotransmitters, let's have a look at their cortisol. See cortisol, we can see that
I think it's on the other reports. So this is just
sure. We'll look at both the cortisol as well as the DHA. Let's look at this is the hormone test. So let's look at the hormones. Now we can see DHA is elevated. Now if DHA is vitality, it's within normal range and it's nice and high, so that's great. It's vitality, libido, muscle tone, memory, concentration. Decrease of DHA also causes depression. So just with those neurotransmitters in the past, if you say to me, does this patient have problems with onset, or do they have problems with latency of sleep? I would suggest that they have problems with latency of sleep. In other words, sleep maintenance, because the GABA was low and serotonin was sufficient. So generally you'd give melatonin for a short period of time and then you increase that with your GABA pathways, okay? Now the next thing we look at is their hormone levels. So within the hormone levels, this melatonin is high. So this patient is not melatonin deficient. Why? Because their serotonin was high and the serotonin makes melatonin. So we know that the melatonin is not an issue. This patient is anxious. This patient cannot relax. The progesterone's fine, testosterone's high. Why? Because DHEA makes testosterone. So if you have a look at some of my, wait a minute, where are we? In the website, in my website here, which is Vanita Dyer, there's a lot of information there and you're welcome to have a look at the various resources. And there's heaps of information. There's a lot of checklists. There's all sorts of things that are freely accessible to you. So the checklists here, there's checklists, there's questionnaires, information sheets, slides, etc. So let's have a look at a hormone. Here we can see this particular patient has a very high DHEA. Their testosterone's high. So we'd expect to see them rather anxious. They're not excessively high, but they're definitely high, right? Now, testosterone in a male does two things. It either is reduced by 5-alpha reductase to dihydrotestosterone, or it is aromatized to the estrogens. And as we can see that and if the cortisol is really high, that high stress will drive down progesterone and it'll steal from DHEA. That's the pregnenolone steal pathway. So we can see this patient's got high DHEA and high testosterone. So let's have a look at their results. Progesterone's fine, melatonin's high, testosterone's high, and the estrogens are high. That means that this patient is aromatizing. So an andropausal patient will typically, a male that's over age 50, age 60, these are patients that will tend to have a high level of estrogenization of their hormones. In other words, a male with a receding hairline, a pot belly, lack of elasticity of skin, no muscle tone, etc. These are patients that will convert their testosterone quite easily to estrogens, and they become what we call grumpy old men. So I'm sure some of your patients fit that profile, and this is what we need. What we need to do to rectify this is, number one, stimulate the metabolism of estrogen. And how do we do that? We use DIM, I3C. We also need to go upstream and see what's going on with his liver. Is he metabolizing effectively? You know, so that's the next thing we need to look at. Now let's have a look at his cortisols. So which one was the cortisol? Oh, there we go. There we've got some cortisol. So when we have a look at this gentleman's cortisol, this is a simple spit test. So what we've done is we've had a look at his cortisol. Now remember, his serotonin was high, so we're suspecting that there might be a high level of anxiety and stress, perhaps aggression, perhaps agitation, perhaps irritability. And why? He's waking up early in the morning and he's firing on all cylinders. That means he hasn't slept the night before. So we then like GABA to help that cortisol. So what actually drives down that high cortisol? The first thing I would give the patient is the choline derivatives. Acetylcholine helps with memory, concentration, focus, attention. So we need to stimulate that metabolism of cortisol. We not only need to give him GABA support so he maintains a longer sleep, but we also need to drive down that cortisol with choline derivatives in the morning. The rest of the time, we'll need to give him adaptogenic herbs. So as we can see, he is firing on all cylinders down there, and his total cortisol is really high. His DHEA is high, normal. So he is a wired, tired, person. He's just going on all cylinders. Like, somebody's normal would be, an allostatic or a sort of a homeostatic normal, and others just operate at a different level, and that's an allostatic normal. They're just going on at 100 miles an hour. So this is a person would do well with meditation, psychotherapy, your choline derivatives, and by that I mean phosphatidylserine, phosphatidylcholine, lecithin. Those are the sorts of phospholipids would actually help that drive down that excess cortisol. So that's what we have to do with cortisol. The next one we have a look at is his food panel. So when we have a look at his food issues, we can actually see that, remember, he hasn't got, you've done his IgG test.
Yes.
Not much to report there, except, as you can see, he's got nothing much that's out of the range. A few things just on number one, black tea could be a little bit something that he could do away with. But his major complaint is dairy. Now, as an Asian, one thing we need to be aware of is what are you genetically attuned to? Some population groups have never been brought up with dairy. This particular patient obviously has westernized and has now incorporated dairy. Now, what dairy does is it's lactose intolerance. If you're getting older, you're not being able to convert pyruvate to lactate, you become lactic acidotic. In other words, you have lactic acidosis, means that the system is acidic. So we therefore need to drive down that acidity. And, you know, when we're stressed, guess what? We're acidic, right? And what do acids do? They corrode the body. So, you know, what does acid do to the body? If it corrodes the mucosal lining within the gastrointestinal mucosa, guess what? You're going to have food allergies. You're going to have food intolerances. You're going to be bloated. You're going to feel yucky in the gut. And this is one of the reasons why we look at food intolerances. The next one we have a look at is his hair mineral analysis. So now, before we do the hair mineral analysis, just let's look at his genomic profiling. So with his genetics, what we have discovered is that he has methylation is really important in that it drives, it maintains homocysteine. If homocysteine is too high, then we have a problem with inflammation, diabetes, cardiovascular diseases, cancer, etc. If it's too low, we're not able to produce enough glutathione. So what we now need to be aware of is that he has a problem with MTRR, which is a conversion, methionine reductase, it's conversion from homocysteine through to methionine in order to cycle through the SAMe pathway. This particular genetic polymorphism is directly associated with B12 deficiency. So this patient needs B12. This patient perhaps might need methionine and SAMe to support that SAMe pathway. The next thing we see is he's got no problem with methionine synthase. He's got no problem with AHCY, which is a conversion from SAMe-SAR to homocysteine. So he's got no problem there. But he's got a polymorphism in COMT. So if he's got COMT is catechol O-methyltransferase. This is dependent on methylation cofactors. Now remember, we saw high levels of estrogen, and that clearly indicates that he's got a COMT. He cannot metabolize his estrogens because estrogens need to be methylated by catechol methyltransferase. So it's very important to incorporate these methylating cofactors, not only to help estrogens metabolize and drive down testosterone, but also to help with the adrenaline pathway. Because remember, adrenaline needs to convert to its cofactors, or its metabolites like DOPAC, HVA, VMA. These are the metabolites of adrenaline and dopamine, the catecholamine pathway. So that particular pathway is driven by COMT. So we therefore need to ensure putting basic nutrients back in is the way to go about it. The next thing we see is that he's got an MTHFR polymorphism. So what does that mean? He does not have enough folic acid. So he may not be eating enough greens. He may not be taking enough folinic acid or methyl tetrahydrofolate. So we really need to incorporate those into the system. So finally, we get to his, which one did we miss out on? His hair mineral analysis.
Hair mineral, yes.
So when we're looking at you've done quite a lot of testing for one person, but when we put puzzles together, it's so wonderful. We can actually see. Remember, I said to you that his dopamine was high, right? If his dopamine was high, it will block there's a blockage in the dopamine to noradrenaline and adrenaline pathway. So if we have a look at the pathway of dopamine to noradrenaline, now we can see that the amino acids phenylalanine and tyrosine convert to dopamine. Now we know that dopamine decarboxylase is is converting into, it's needing copper and vitamin C to convert into noradrenaline and adrenaline. We saw in his results, we actually saw that he has high dopamine. But what else do we see? We see high levels of selenium. We also see high levels of iodine in his hair samples. So normally low iodine and low selenium is associated with low thyroid function. We are now seeing that he's got a high level of dopamine. So what does that mean? That means that high level of dopamine is contributing, that dopamine that's so high is contributing towards possible underlying thyroid dysfunction. Okay, why is it high? Have a look at his thyroid. He might be hyperthyroid. And that's why we see, very low levels of, very high levels of selenium. Now, we're also seeing high levels of copper and low levels of zinc. So we all know that copper is needed for dopamine decarboxylase, but typically when you see a patient with high copper, you need good adrenals to make sure that that copper is being metabolized. So if that copper is high, you might see a patient with a lot of headaches, or some patients even have tinnitus, which is ringing the ears, or candida. Some patients, you might give them all the candida therapies and they still have candida. You must correct the copper, so in order to get rid of their candida as well. So in a patient that has high copper, low zinc, you've got to give them zinc, of course, but you may want to give them taurine, vitamin B3, molybdenum, vitamin C. All of these things will drive down that elevated copper and push up zinc. The next thing we see, what else do we see that's high? Manganese. Manganese is high. Now, typically manganese we will see in, because it's needed for the CBS pathway, which is your homocysteine through to glutathione pathway, we can typically see neurological issues. Patients who have high manganese are typically aggressive, they're irritable, they're just irrational in their behaviors. So we need to drive that down. Well, how do we do that? We stimulate that cystathione pathway. We can do that through N-acetylcysteine, cysteine, or activated forms of cysteine and cysteine. The next thing we see that is of significance is the fact that the aluminium is high. So you might want to inquire, is that aluminium excessive? Is he using aluminium containing underarm sprays or hair sprays or something like that? Or is he cooking in utensils that are aluminium rich? So we need to deal with that. Lead and mercury are high, and it's typically known that heavy metals are responsible for neurological dysfunction. So he may have come to you for sleep issues, but this is now giving us a clear indication that we need to do a couple of things. One is, in summary, this is what I would do, and I'd like to ask you what you would have done as well, so that we can actually share these ideas. The first thing I would do is actually take him off his melatonin and definitely support. Lots of L-theanine, lactium, and GABA support, glutamine, etc. The second thing that we need to do is we definitely need to check out, is that a problem with him in terms of a thyroid dysfunction? Does he have a thyroid issue? That we have to support methylation, because methylation is underpinning every biological pathway. We've got to drive down that excess copper, and we do that with your zinc, your vitamin C, molybdenum, and so forth. We also need to, at the last stage, we need to chelate, okay? And I'll give you really good ideas about chelation. As far as his diet is concerned, I would actually eliminate dairy from the diet. I would start to alkalinize this patient. I would rectify the way their body's absorbing, metabolizing, digesting, and excreting. We don't know anything about his gut, but inquire about that. You may want to do a complete microbiome map to identify, send a sample of stool off to the lab to really identify what's going on in his gut. Because if his immune integrity is impaired, then he's going going to have food allergies, etc. Now, one of the easiest ways, and this is a well-published study that was actually studied in Melbourne and published as well, is a bunch of kids who were anaphylactic to peanuts. They had been exposed to high doses of Lactobacillus rhamnosus. And after 3 months, they were exposed to the peanut protein, and 80% of these kids could tolerate peanuts. So guess what? We can actually rectify patients' food allergies quite easily. We definitely need to ensure that we are driving down that cortisol by giving the patient some phosphatidylserine as well as adaptogenic herbs. We definitely clear that estrogen. How? By stimulating COMT, right? And secondly, so COMT by methylating cofactors. Secondly, we need to stimulate that estrogen clearance. We need to stimulate glucuronidation. How do we do that? We give them a good liver detox with calcium D-glucarate. We need to stimulate the metabolism of estrogens. How do we do that? We give them indole-3 carbinol, diindole methane. Your brassica, your sulforaphanes, all of those will stimulate metabolism of hormones. And we've discussed that one. We've discussed the thing. We've discussed that one. How do we deal with his minerals? We really need to drive down that copper. We also need to drive down that histamine. The histamine was really high. So we need to support the patient with methylating cofactors. And that brings me to the conversation of the heavy metals. So, Dr. Chan, would you like to tell me what you did for the patient, and then I'll go through what we can do with heavy metals?
With regards to which reports, Vanita, that you would
it doesn't matter. How did you had all of these reports in front of you, and now it's a matter. Now, what do I do first? Because as a patient walks through that clinical door, we're seeing he can't sleep. So now we've discovered through all these tests that there are lots of metabolic aberrations.
Right. Yes. So the presenting symptoms is sleep problem, right? And so our initial prescription of melatonin seems not to be justified. So this is again emphasizing the importance of doing lab tests, right? Because we assume it is because of a lack of melatonin, which the results show it is not, or maybe because of our prescription to some extent is melatonin was quite high, but we were careful to use only 3 mg. So I don't think that itself would explain that high level. So the high serotonin could also be our prescription of 5-HTP that we gave him initially. So we have taken all those off since the serotonin was showing such high results, right? And we try to enhance more GABA. You know, we have initially given him some GABA prescription, and so now we will enhance that even more. And bringing down the cortisol, like you say, is a prime objective. So we have given him phosphatidylserine, ashwagandha, especially in the morning, and also late at night, so that this would not inhibit his melatonin, the high cortisol, right? That would also take care of the adrenaline as well. And we have added certain cofactors for the methylation, like SAMe, so certainly the methylfolate because of the MTHFR, compromised methylcobalamin as well. So we have given him all those. But it's really the revealing, hearing from you the damage high copper, and
Sure.
But I think one of the big culprit would be the high copper. I think we need to do more to
we need to drive down that excess copper.
So can I ask because he has also been on selenium, so that means take him out of selenium.
I would actually look at this patient's T3, T4, TSH, reverse T3. I'd look at his thyroid antibodies, TSH receptor antibodies, antithyroglobulin antibodies, thyroperoxidase antibodies. That gives us an opportunity to rule out, is there a thyroid issue? There's too many clues there that's telling us that there's a thyroid issue there. And anybody that has a thyroid problem would most people are actually hypothyroid. They're tired all the time, and these are patients that are typically thyroid deficient. But there are few people that are hyperthyroid. In other words, they have an overactive thyroid.
Right.
Now, Dr. Chan, there is a comment from one of your speakers in the chat that says that it's Greek to some of the material is Greek to some of them, purely because some people.
we have a mixed audience here. Maybe have a number of doctors and naturopath, but we do have others. More in psychology.
Fantastic. Excellent. Excellent. So we all have to start somewhere. So when a practitioner, a psychologist, is dealing with psychiatric health from a psychological perspective, and you want to look into it from a functional perspective, there's only two tests that you really need to get your teeth into. And that is to check if your patient's stressed. So have a look at their cortisol levels, okay? And the second test is their neurotransmitters. So have a look at their serotonin, GABA, and the dopamine, etc. Now, I'm going to give you the opportunity to really dig deep. And what does it mean to have a high level of serotonin or a low serotonin? What does it mean to have a high dopamine or low dopamine? And how do you fix that? Because there are some patients who use SSRIs and they feel terrible. Some of them feel happy, but most of them feel, oh, look, I'm taking these happy pills and they're not making me happy at all. So what are the options available? Most of these patients who are not responding to SSRIs are often patients who have other issues. They may be GABA deficient and not serotonin deficient. But unfortunately, a doctor doesn't measure these neurotransmitters. So what do they have in their basket of pharmaceutical toys? We have SSRIs, SNRIs, mood stabilizers, we have benzodiazepines, we have antipsychotics, that's it. So we just grab from these basket of toys until a doctor finds one that works best. But if you're using the functional perspective, you can actually see, is this a serotonin issue, or is it a dopamine issue, or is it a GABA issue? So for those that are starting out in the area of expanding the functional aspects of their for their mental health patients, stress is always the underlying issue. So have a look at the cortisol issues. And there's definitely more education in both of those areas.
That really make a lot of sense. Yes.
Yeah. So what did you prescribe for this patient, Dr. Chan?
Yes. So we have taken him off the 5-HTP, and even previously we have prescribed him some testosterone because he's like 50 plus, and so we have taken that off because of the high testosterone showing, and we have sort of maintained the chrysin so that he can convert
stimulate the metabolism. Yeah.
Indeed. So we have done that.
So there's some really great herbs, chrysin, progesterone. These are aromatase inhibitors. Saw palmetto, epilobium, zinc, Pygium, and they often contained in one single men's health formulation. So I'm happy to share some of those formulations with you if you wish. Okay,
Sure. Yeah, and I guess we can maintain the DHEA even though it was on high normal, but it's probably
you can often give patients don't need DHEA long term. Generally, most patients who need DHEA, you do not want to stimulate adrenal hyperplasia because he's got high cortisol, he's got high DHEA. You don't want to do that. So these are patients. Often you will find patients who have females who have polycystic ovary syndrome, or even patients who have adrenal tumors. These are patients, any form of adrenal hyperplasia, Cushing's syndrome, for example, will have high cortisol. And these are patients that are also likely to have high DHEA. Now, it's because his cortisol was normal in the afternoon and the evening, we therefore suspect that he hasn't got Cushing's, he hasn't got an adrenal hyperplasia, but he's often stressed. His adrenaline is just fight, flight, fright all the time. So we got to drive that GABA pathway up, and we've got to ensure that his cortisol is driven down. That alone will fix his sleep issue. Okay, there's some amazing amino acids that help that pathway. The amino acids such as ornithine, glycine, serine, you know, and GABA, which is glutamine as well. These are all those amino acids, L-theanine, inositol, all of those amino acids will actually make a huge and a profound impact for this particular patient.
Right. That is interesting. We actually had an earlier test for him, which we haven't shown, and that was showing, I remember, very elevated GABA. Right. So yeah. So now that has come down. So I think it's time to put it back up to enhance it. I guess we have to modulate.
GABA and serotonin work in cohort with each other. They're two partners in crime. GABA will overshoot when serotonin is deficient and vice versa. So the one will often balance the other out. So if serotonin is high, give the patient GABA. If serotonin is low, push up the serotonin and support the GABA as well. So serotonin and GABA are generally, you'll often find the patient who's depressed will have some sense of anxiety as well, and they just can't relax, or they too much. Their GABA might be overshot, they're sleeping all day and they're feeling sad.
Okay. So to recap, we need to check out what is going on with the thyroid, do a reverse T3 even to see.
Yes, that would be valuable for you to determine is there, because he's got high iodine and high selenium. There's something going on. He's got high dopamine, and we know dopamine, those are markers that play a role in his
right.
His
and so
driver.
Yeah. So previously we have given him L-DOPA, so we will stop that definitely because of the high dopamine, and like I mentioned, we might even take him off iodine and selenium given the high level until we find out what is.
That's right. Once you've established where his thyroid levels are, then you can make that decision yourself as to whether he needs those supplements. Now that brings, has anybody got any questions? Please pop them in the chat box so that we can answer them. And in addition to that, we mentioned that heavy metals. Now, one thing I do, would you like me to share what I do with my heavy metal patients?
Definitely, yes, please do.
So often patients who have heavy metal toxicities will have a lot of neurological issues, and that's clear. It's in the literature, it's well published. So what we need to therefore do is we need to chelate it out. There's two ways to chelate it. We can go through the pharmaceutical route, and that is using IV chelation. So we do a pre-chelation challenge with DMPS or DMSA. and then we determine the dosage of EDTA, DMSA, DMPS, IV. Okay, vitamin C, glutathione, lipoic acid, these are all IV. Now, there are some practitioners who are not using IV chelation. So these are patients like naturopaths and people who don't want to go through the IV route. These are people that would possibly do very well with something like zeolite or charcoal, activated charcoal. It's very important to ensure that you're stimulating liver clearance. So give the patient things like liposomal vitamin C, liposomal glutathione, and a 6-week program of supporting them with liposomal glutathione, N-acetylcysteine to stimulate the sulfation pathways, vitamin C to stimulate the antioxidant free radical damage pathways. Now you've done that throughout that time, but what the patient does is infrared sauna for about 40 minutes or so, 3 times a week. Get the infrared sauna, take some activated charcoal prior to that. Take a dose of activated charcoal, get into the infrared sauna, come out of the sauna, and then have and continue to use your vitamin C, glutathione, N-acetylcysteine, as well as zeolite. Those are the 4 things that they must use throughout the month or the 6 weeks. Infrared sauna 3 times a week. So they have a 40-minute session 3 times a week. And when they get out and get into the shower after the sauna, then they hop into stimulate the vagus nerve. So normal temperature, and then cold, and then hot, and then cold, and then drink a lot of water after that. So your infrared sauna is actually really powerful in terms of chelating and detoxifying. So you're detoxifying and chelating all at the same time. And this is a very powerful, any patient who has severe autoimmune conditions, Lyme, mold, borreliosis, chronic fatigue, fibromyalgia, ME patients, these are patients that will do well with a protocol like this. But you cannot start this until you get the basics done first. Because if you give somebody a protocol like that, they will tend to have like a Herxheimer reaction. They might react to what you're giving them. So you've got to restore some of the chemistries up front, and then start. The last step you do is your chelation therapy.
It is very reassuring to hear that we have a more holistic way to chelate without IV, because IV, I'm always very hesitant. It will chelate out a lot of very useful stuff as well, useful minerals.
Not only that, some people have IV chelation and all their heavy metals are drawn out into circulation, and they might re-lodge. If it's not eliminated and detoxified correctly, it just goes and lodge in a different tissue. And that's the one.
Yes.
So IV chelation is used with caution. Yeah.
Yes.
So are there any questions at the moment, guys? Those that are listening, any points of interest, or would you like to learn a little bit more about adrenal dysfunction or neurotransmitters?
I would also want to talk a little bit about follow-up tests later, but Vanita,
Sure.
For this patients, whether like the fiber profile would be useful,
Yes.
to do, for example.
Yes.
Yeah.
Because he had a high level of copper. This is a problem. Because he had a high level of copper, we need to know how much of that copper is damaging. How much is it oxidized? Because oxidized copper is as dangerous as mercury in the body.
Wow. Okay.
So doesn't hang around on its own. It actually is latched onto ceruloplasmin. That's like your hormones are latched onto sex hormone binding globulin, etc. Your copper is latched onto ceruloplasmin. So if you've got poor adrenals like this patient has, The adrenals cannot make ceruloplasmin. So guess what? If you've got poor adrenals, you cannot make ceruloplasmin. Therefore, the copper, you might have the right amount of copper, but that copper is not being carried by ceruloplasmin to the tissue. Instead, that copper is hanging around and becoming oxidized.
So it makes sense to do a 5-fold profile to see
Exactly.
what the ceruloplasma is doing, whether
Exactly.
there's sufficient or not. And if they are not, then any way to increase the ceruloplasma?
Ceruloplasmin. And
Yeah.
ceruloplasmin can be easily upregulated with a couple of ways, supporting adrenals, vitamin C. There's a whole protocol, and that's all in the course material. By the way, all of this material is expressed in detail, not only in my book called Alchemy of the Mind, but it is also available in the course, and I will share the course with you. Somebody said, can you please share information on adrenals? I'm happy to discuss that at another event, but I've got that all recorded. So it's great to know, what does it mean to have a high cortisol? What does it mean to have a low cortisol? What does it mean to have a normal cortisol and high in the afternoon and low? What does it all mean? And that is expressed in the course material that I've supplied. So I'm going to do one thing. I'm going to share with my compliments the area of adrenals with the group, and then those that want to take advantage of the course, it's really clinical and practical. It's not academic heavy. It's really looking at the numbers and giving you an idea as to what you can do with the with the patient who has a high cortisol or low cortisol. Because people like to see themselves in color. They know that you're giving them, as psychologists, you're all treating your patients using psychotherapy and the various versions thereof. But when you say to the patient, look, we can actually measure how stressed you are. Are you at adrenally sufficient or insufficient? Or are you adrenally exhausted? Are you at the resistance phase, etc.? We can figure that out just through the tests, and we can actually start rectifying it. The next thing we can rectify is they all come to you because there's something wrong. There's an imbalance in their neurotransmitters. So we can measure them. And so definitely have a look at the resources. In the site, I will send you the various links so that you can look at various questionnaires that you can compile for your own patients. Of course, you have Hamilton scores, you have DAS scores, you have all sorts of scores. But the important thing is you need to look into their chemistries to be able to identify where they're at.
Fantastic. I think that there's a question about the dyspraxia and muscle tone on the chat box.
So when you have, like to know something about dyspraxia, low muscle tone and squint, also part of poor muscle control. If somebody has dyspraxia, they have you have an opportunity to identify what drives the myelin sheath to actually produce muscle tone. It's amino acids and it's nerve induction. So how do we identify where the metabolic blocks are in terms of amino acid utilization? What's happening? Is there enough oxygen to that muscle tissue, or is there a lack of protein? So we can identify an amino acid analysis, and we can look at an organic acid to identify, is there a problem with the food that the patient's taking to produce enough ATP, which is actually associated with muscle tone, okay? Because we need oxygen to ensure that the muscle tone's working effectively. So perhaps there might be more to dyspraxia. There might be an issue associated not only with muscle tone, but is there a problem with nerve induction? Is there a problem with neurological dysfunction? So just asking a question, what would you test for dyspraxia? Definitely look at the amino acid profiling and then support that.
And organic acids. test as well.
This would be very valuable purely because you're able to identify the metabolic blocks in terms of how is it that this patient is not able to oxygenate and get the blood supply to that muscle tone or the muscle mass, okay?
Right.
The muscle,
Sure.
the myelin sheaths. What's going on there? Why is there not enough nutrients there? And muscle is made out of protein. What's protein made out of? Amino acids. So amino acids is the way to go about it.
Right. Sounds good. Well, the inquirer can ask us more about those tests later, definitely. And
Sure.
And it's also in your book, the amino acid, alchemy of amino acids.
Yes, right? That's correct. That's correct. So if anybody in the audience would like another session later down the line, perhaps just to go through adrenals as an example, you're welcome to do that. Please request that with Dr. Chan and we can take that from there. In the meantime, are we done? Are we any other questions?
Yeah, we have 3 more minutes, and yeah, if there's
So a patient like yours, I would definitely look into retesting their adrenals, retesting their neurotransmitters, and you only do that about 3 months after you've really got all the chemistries back on track. All right.
Right. Yeah, that'd be good. And even the neurotransmitters, retesting.
Exactly. Yes.
Yeah.
So Nada, you mentioned you'd like another session. Would you like to have a session on, adrenal function so that you get an understanding of stress in a patient, or would you like to have another case study presentation?
So
sleep problems, great.
Sleep problem.
All right. So we can definitely look into sleep in a little bit more. I'll put a presentation together for sleep in relation to what age is appropriate for a neurotransmitter test. Generally, most patients who have problems in their adulthood, but they're also kids that have autism, ADD, ADHD. Those are patients I would probably look at in terms of a FIFA profile together with their neurotransmitters. So really from 2-3 years onwards is when you can do a neurotransmitter test, but it's possibly not ideal for a young child. You can definitely use the tests from 2 years onwards. It's a matter of looking at how are we going to read that. There are reference ranges for under 11-year-olds, but does that mean a reference range for a 2-year-old is the same as a 10-year-old? Perhaps not. Right? So that's the reason. It's not so much the neurotransmitters. You'd want to look at the nutrient profiling. All right?
Right. By nutrient profiling, you mean the...
We're talking about FIFA, we're talking about vitamins, etc.
Yeah, indeed.
All right.
Fantastic.
So I hope you all enjoy that, and it opened up your eyes to a lot of areas to sort of overlook. And we as professionals can actually dig deeper in our patients' history, clinical history, and the outcomes are profound. When a patient walks away, you've done all the damn psychotherapy under the sun, and they're there for and they're doing the same thing, and just supporting their nutrient output so quickly, just with adaptogenic herbs, for example, and they shift. They then start to say, well, I can now take on board the CBT or ACT or DBT therapeutics as you come along.
Indeed. That's wonderful. Well, thank you so much, Vanita. It's great seeing you again.
Pleasure. It's good to see you again too.
And I will organize more of this that I'm sure everyone finds very, very insightful and very helpful.
All right. Yeah. So the next session, if we'll talk about it, but if you like, we can talk about another session later down the line. Thank you so much, everyone, and thanks so much for attending. And if you have any other questions, you're welcome to give me a tinkle. Dr. Chan will give you my contact details, and
sure.
I'll send to you the appropriate
yes.
links.
So all just to end, all the lab tests WellLab conducts. We have access to Vanita as a consultant to go through all the results as well. So let me know if there are any tests. We have a practitioner directories. All these tests are available to patients as well. So wonderful. Thank you, Vanita. We'll catch up soon again. Bye now.
No problem. Thanks. Bye.
Bye-bye. Bye-bye.